All right. Hi, everyone. Hello and welcome to the first session of the Data and Information Sharing Learning Community Project Coordinators track. So just a look at what we'll be covering today. We'll start with welcome and introduction, where I'll introduce you and speakers for today's session. You'll have a chance to see what other JP grantees will be a part of this learning community. Then we'll have an overview of the performance measurement tool by Gentry Schaefer, who will discuss the tool as a whole and the benefits of collecting key data points for both grantees and the funder, Bureau of Justice Assistance. Next up, you'll hear from Dr. Faye Taxman about the Cascade model and the process interface measures. And then finally, there'll be some time at the end for questions and answers. We're really hoping that this will be a collaborative and open learning community. We really hope to be able to use this time for discussion among participants in this community. Okay, so first of all, welcome to all of you, and thank you for taking the time to join us today. And thank you to our speakers for taking the time to join us and share their knowledge and expertise with us. So first up, we have Gentry Schaefer, who is a research associate at Booz Allen Hamilton, which serves as the contractor or a contractor to the Department of Justice, Office of Justice Programs, and oversees the performance measurement tool, which I'm sure many of you are familiar with, if not all of you. Then we will have Dr. Faye Taxman. Dr. Taxman will be the expert consultant for each of the 4 sessions of this learning community. For anyone who is not familiar with Dr. Taxman, she has a ton of experience working with researchers and project coordinators and jurisdictions across the country in this field, and really brings a lot of expertise to the table. So we're very excited to have her on board. And I am Sheila Tillman. I'm a senior policy analyst here at the Justice Center, and I'll be facilitating the project coordinators track of this learning community. So you'll be hearing from me quite a bit in the next couple months. I've worked on a variety of projects here at the Justice Center, including providing technical assistance to JMHCP grantees. So I know I've worked with some of you. So hello to those that I have worked with, and I'm excited to work with, for the first time, those that I have not had the pleasure of meeting yet as part of the TA process. So I'm going to go over this stuff pretty quickly. I think you're all familiar with who the Justice Center is and what JMHCP is, but I'm just going to take a little bit of time to go through it quickly now. So the Council of State Governments Justice Center, we use the power of our membership organization, which represents state officials in all 3 branches of the government, mixed with the policy and research expertise to develop strategies to increase public safety and strengthen communities. How we work, we bring people together through in-person meetings, conferences, trainings, or through virtual opportunities like this learning community. We drive the criminal justice field forward with original research. We build momentum for policy change, and we provide expert assistance like the technical assistance we provide to each of your jurisdictions as part of the JMHCP grant program. Our goals at the Justice Center are to break the cycle of incarceration, improve health, opportunity, and equity, and expand what works to improve safety. Just a quick overview about Justice and Mental Health Collaboration Program, JMHCP. I imagine you all are pretty familiar with the JMHCP grant since you are grantees, but the JMHCP program supports cross-system behavioral health and criminal justice collaboration for individuals with mental illnesses or co-occurring mental health and substance use disorders who come in contact with the justice system. The U.S. Department of Justice, Bureau of Justice Assistance, generally referred to as BJA, is the federal agency that oversees and manages the JMHCP grant program, among other grants. Their mission is to provide leadership and services in grant administration and criminal justice policy development, to support local, state, and tribal law enforcement in achieving safer communities. Okay, so what brings us here today? The Data and Information Sharing Learning Community. there are 2 tracks to this community, one for project coordinators and one for researchers, both of which are made up of JMHCP grantees. This is the first session of the project coordinators track. We created this learning community as a closed learning community. Basically what that means is that the same group of project coordinators will be invited to each session. In doing that, we're hoping to create a peer learning community of people who are working on similar projects and will help foster discussion amongst participants. So we really encourage everyone to participate in the discussion. You'll see at the lower right-hand corner of your screen, there is a chat box as well as a Q&A box. Throughout the session, I encourage you to utilize those to ask the presenters questions, or if you just have a comment, you can use the chat function. Highly encourage you to use those ways of communication in this platform. So this track will discuss how to use an organizing framework for systems analysis and data-driven decision-making. And I'll run through the topics of the sessions in a moment. But we really hope to hear about your experiences in data collection and analysis to create a collaborative community experience. So I just want to take a second to thank everyone who submitted responses for exercise 1. Moving forward, after each session, we'll send out additional exercises to be completed prior to the next session. The responses to the exercises help us to know where you are at in your different processes and will allow us to tailor content to your needs. So we hope that this will be a good way to incorporate your on-the-ground experience into topics in discussion. And again, we encourage everyone to participate, and we hope you find this approach useful and as exciting as we do. So this session will have a virtual structure of panelists and attendees. But for the next session, we'll have a virtual structure where people can turn on their cameras and phone lines will be open. Because we do want to, again, encourage participation and folks to share their own experiences. So we're not going to ask everyone to turn on their cameras today without any warning, but for next time, if folks are willing and able, we would love for everyone to join by video. It'd be really nice to see all of your faces. So we have 19 project coordinators on this learning community representing 19 JMHCP grants. As you can see, we have folks from all over the country. Here I only have listed the counties, but this includes a variety of agencies, including jails, law enforcement, courts, behavioral health, just to name a few. And this is what really makes the JMHCP model special, is that we have all these different agencies and all these different collaborations together in one place. So we think it's a really great opportunity to learn from what folks are doing in other jurisdictions and in other agencies. Just a quick look at the upcoming sessions. After this session, we'll have 3 other sessions in August, October, and December. Stay tuned to receive those calendar invites and additional information from me. I'll be in touch with you all in the next couple of months to be able to get you those invites and get you additional information on the sessions. So again, as we have our speakers discussing the content today, I encourage you to enter any questions or comments into the chat box and the Q&A box at the bottom right-hand corner of your screen. We'll address these, if it makes sense, we'll address these during the actual presentations. And again, we should have time at the end to answer some additional questions as well. So I'm now going to throw it over to Gentry to talk to you about the performance measures and the performance measurement tool.
Thanks so much, Sheila. As she said, my name is Gentry Schaefer. I am currently supporting the Bureau of Justice Assistance, doing performance measurement and performance management analysis as the, I guess, subject matter expert on performance measurement. So today, we're going to review the performance measures reporting and go over basic questionnaire structure and cover common reporting challenges. And then at the end, there'll be a quick live Q&A session, but as Sheila said, feel free to, at any point while I'm speaking, just ask any questions in the chat box so that we can answer them for you. At the end of my section of the presentation, you as a grantee should be able to understand the JMHCP performance measure reporting requirements, why BJA requires these performance measures, and then any sort of common challenges. So let's start with a brief overview of what performance measures are and how the collection of these specific metrics benefits both you as the grantee and BJA. So first, what exactly are performance measures? Performance measures are numeric descriptions of an agency's work. They are based on data, and when analyzed, tell a story about an agency's activities towards goals and objectives. It also provides results of the work being done. Performance measures are made up of inputs, activities, outputs, and outcomes. So let's quickly go over each one of those before moving on. Inputs refer to the program resources. Examples include grant funding, where we ask about your program's funding allocations by program activities and personnel. We get personnel information through a variety of questions about cross-sector partnerships and community participation. Activities are the actions that convert inputs to outputs that eventually result in measurable progress towards your program's goals. These can include things like trainings, meetings, partnership development, data analysis, and strategic planning. Outputs are the countable products or services that result from these actions. And outcomes speak to longer-term program goals. They are generally associated outcomes and can be found in the outcomes section at the end of the performance measure questionnaire. So, yes, of course, BJA must comply with the Government Performance and Results Modernization Act, but honestly, that's not the only reason that BJA collects performance data from grantees. Performance measurement benefits both BJA and the grantees. BJA uses these performance metrics, the performance data that we get from you, to identify areas of success and potential opportunities for improvement. We also track grant progress towards your goals and helps us understand how the funds are being distributed. So this slide really talks about the type of data that a grantee is going to provide when responding to the performance measures, and then the direct benefit to BJA. So I've got a couple of sample performance metrics. So like the first one, on average, how many days does it take for an individual to begin receiving treatment services after receiving a referral? The direct benefit to BJA is that we're able to highlight areas of success and examine potential areas of improvement. This enables BJA to respond to external requests like congressional inquiries or requests from the media. Another sample performance metric is what obstacles, if any, did you encounter that have had an impact to your project? The direct benefit to BJA is that it helps us identify needs, your needs as a grantee, for training and technical assistance, or any revisions to the program design or implementation that need to be made on our end. It helps us track your activity and your progress towards your goals. The third sample performance metric that I have on here is please indicate if you used JMHCP funds to provide any of the following identification and or treatment services. And a question like that would be a checkbox, and where you could check everything that applies to that question. So the direct benefit to BJA is that it enables us to understand how your funds are being distributed, and that in turn informs budget, strategic planning, and future funding. So how does it benefit you as a grantee? You as a grantee can also use performance measures to accomplish many of the same goals, like identifying areas for improvement to focus internal efforts, proactively request assistance to address challenges, and develop evidence of program progress that can be used to enhance advocacy and sustainability. These performance measures that BJA is asking should supplement the metrics that you're already collecting. So again, I've got some sample performance metrics here and how they directly benefit you as a grantee. The first one says, please enter the number of individuals receiving mental illness or co-occurring identification or treatment services. So they're asking, or we are asking, for the percentage of the individuals screened and referred to services who actually end up receiving services. So a question like this is going to be a multi-tiered question. It's going to ask you for the number of individuals that were screened. It's also going to ask you for the number of individuals who were referred to treatment services. Then the last part is going to ask, of those who were referred to treatment services, how many individuals actually received it. So you get the percentage by, using the metrics from those three different questions to see basically the percent of individuals who are screened who end up receiving services. And this directly benefits you as a grantee because it generates evidence, tangible evidence of your progress towards your goals, which can enhance resource advocacy for sustainability. The next sample performance metric is, did the project provide or facilitate training to project staff or individuals involved in the project? The direct benefit to you as a grantee is that it generates evidence of progress towards your program goals. The third one is asking about the recidivism rate of your participants. And the question would be something like, according to your definition of recidivism, how many program participants have recidivated since the beginning of the grant program? And the direct benefit to you is that it identifies areas for improvement to focus internal efforts. BJA is currently working on simplifying and consolidating the existing measures to reduce the burden to you as grantees, but the basics are going to remain the same. As mentioned in the earlier part of the training, the questions in your performance measures questionnaire are made up of two main categories. The first is the quantitative program performance measures, where you enter the numeric data you collect over the course of the reporting period. For example, how many dollars were spent on law enforcement equipment during this reporting period? The second type of question are the qualitative narrative questions. These questions are open-ended and do not require a numeric response, but can contain numbers. The types of questions that this would be would, what type of equipment was purchased with BJA funding, or what challenges did you face in completing your program goals? Just keep in mind that these questions are meant to capture the full experience you have when conducting these activities with BJA funds. So the more information you provide, the better. The quantitative data you report is used to establish baselines and track performance against your program goals and create a nationwide picture of numeric data for BJA. The narrative questions, being open-ended, gives you as a grantee the chance to express in your own words how your experience has been. Both of these categories are equally important for your reporting, and really just take every possible opportunity to ensure the accuracy and integrity of your data. So next, we are going to go over the specific types of reports. Let's see. The reports are generated based on what we ask. So the questionnaire is structured with 3 different types of questions: multiple choice, multiple response, and open text. Additionally, there are 3 main functions of the questionnaire. There are baseline, carry forward, and skip flow. So the multiple choice questions are self-explanatory. They allow you to select the response that best reflects your project activity. And with multiple response, you can select all the responses that will apply. We just went over open text. You're able to provide, both text and numbers. As far as the functions go, the baseline questions collect information on activity that took place before your grant became operational, so that it enables us to compare pre and post grant activity. Carry forward questions reduce the reporting burden by not requiring grantees to enter responses to questions where information is likely
you miss out from this 70
to remain stable. Skip flow questions also reduce reporting burden by allowing you to skip sets of questions that are not applicable to your project. So that's another thing that we're working on internally to try and reduce the grantee burden as far as the measures are concerned. Many of the questions in JMHCP's performance measures questionnaire are related. So we'll quickly go over common reporting challenges that, I think I may have, nope, I didn't. Thought I skipped the slide, but I didn't, so we're good. It's really important to report consistently. We conduct data verifications after you report your data, and as analysts, we examine the related questions to ensure that you're reporting consistently. So here are just a couple of examples as it relates to law enforcement, and and these are arbitrary. Like in question 21, it asks if your agency has policies or procedures when responding to mental health related calls for service. So then in question 22, you are also asked whether or not your policy addresses certain aspects or topics that are listed in question number 22. They're interrelated. Other types of questions include saying, how many sworn police officers or specially trained officers do you have on your department? And you say you report 50. And then the next question asks, of those specially trained officers, how many of those individual officers responded to mental health related calls for service? And you answer 75. Well, logically, that doesn't make sense. If you only have 50 specially trained law enforcement officers, you can't have 75 people who are then specially trained responding to calls for service. So we try and pick out outliers like that to make sure that the data is as accurate as possible. So what happens to your data after you report? The team that I work for is called Planning, Performance, and Impact Team. So we assess, like I said, your data consistency and accuracy, and then we reach back out to you as grantees with any sort of potential issues. Program grant managers also play a really big role in enhancing performance data quality. They conduct site visits and identify documentation to assist. So to wrap up, I'd like, yep.
I was just going to say, I was just keeping an eye on the time, and I want to make sure that we had enough time to move to the next portion of the session today. So yeah, wrapping up comments would be fabulous. Thank you.
Yep, last slide, promise. So I just want to review quickly common challenges with defining goals and objectives and offer a few tips. It's really important to write well-defined goals and objectives to clarify your priorities and highlight criteria for success. The SMART mnemonic walks you through important dimensions of a good goal or objective, and they should be specific, measurable, attainable, relevant, and time-based. And we recommend that you reevaluate your goals twice a year to determine whether they should be updated and use data to drive this process. So this slide is just contact information if you ever need to get in touch with the help desk. And I'm going to stick around to answer any questions you might have towards the end of the presentation. So Sheila, how do I kick the ball back over to you?
I'm going to have my colleague Marilyn do that for us. And Gentry, thank you so much for your portion of the presentation. And folks have questions, please use the Q&A box. And if we don't have time to get to them today, we'll definitely follow up with you all. And Faye, I'm going to turn it over to you to tell us about Cascade and the process interface measures.
Okay, well, thank you very much, Gentry, for your presentation and also reviewing a very important topic, which is performance measures. So having been a BJA grantee, I know that doing the performance measure reports sometimes are perceived as being, a hassle or some sort of, extra burden without thinking about the value of the data that you can actually get out of those performance measures. So today I want to talk about the Cascade model as a way of thinking about taking information from the performance measures and actually using them in a way that you can build coalitions in your own jurisdiction, on your own grant, around key issues. All right? So I want to take us back a little bit to history. And that history goes back to our experience with trying to address the problem of AIDS and HIV in the 1980s and 1990s. And essentially what happened during that period of time is we had an epidemic, just like, we have the COVID epidemic, we have an opioid epidemic right now, but we had an epidemic that we didn't quite understand called HIV and AIDS. And we also lost a lot of people. And it was very hard to get people to galvanize around trying to take care and figure out what to do about HIV and AIDS. And so, some scientists essentially in the early 1990s came around with this idea of a cascade that would allow us to look at how we provide care. In other words, how many people are diagnosed with HIV, how many of those people who are diagnosed are linked to care, how many people have received or retained in care, and then what's the outcome? And in this case, they looked at viral loads because as we now know, if we can get people's viral loads down, we can actually suppress the spread of the virus. And what happened is when at a national level, CDC and others started to think about these cascades, it gave us a picture of what it is, what the system of care looked like, where gaps were occurring, and pretty much within 2 years of us introducing the key medication for HIV antiretrovirals, we basically were able to reduce the mortality rate in half. Now that's a great success story. It's actually pretty important. And I think it's a lesson for us in criminal justice because we oftentimes think about our data as about substance use needs and identification of who needs treatment as something that an individual agency needs to have a hold of, but we don't think about how we can use this data in a way to be system building. Gentry laid out these performance measures, and what I want to do is really transition the performance measures to really think about the task at hand, okay? So one of the things that we learned through the HIV/AIDS Cascade was that we could identify gaps in services in meaningful ways, that we could actually begin to think about how do we increase, reduce those gaps, and how do we actually get people committed to core outcomes. So this is actually from a CDC report. You can find it on their website, on the CDC HIV Care Continuum. It allows us to look at the prevalence of the HIV epidemic as it exists. So we know that 86% of all people living with HIV are diagnosed. We know that 64% are in some sort of care initiated. We know that 49% are retained in care. These are usually, medications. And we actually know that 53% of those people actually are viral load suppression, which is the high end goal here. So you can see this is a pretty simple concept. Of course, this cuts across many different systems. It has to do with the way we can identify people with HIV, the way treatment services get delivered, how we look at care and involvement in care, and then how we look at different outcomes. But this visualization is very powerful and very useful at your systems level to be able to use the performance measures that Gentry has talked about, and that we've actually been talking about, CSG and myself, for about 6 years now, maybe 7 years, since we did the interface document several years ago. So what am I talking about, the interface document? First, let me just begin that in the CDC document, they have a definition for each of these different aspects: diagnosis, receipt of care, retained in care, viral suppression, and link to care. I'm not going to read through those right now. I know that these PowerPoints will be available to you, and I encourage you to actually pull up that CDC infographic because it's very informative and very easy to read. And between you and I would say that as part of your role as coordinators, trying to produce a document like that tells the story of your own system is a great start. And this is why we combined the PMT measures with the Cascade discussion. And a lot of the information that you collect for your PMT is actually useful for the Cascade. So you can get double duty about how you use that data and actually provide a way to more effectively use the data. Now, as I said, Sarah Wasberg, Katie Halbert, and myself, produced a document that's called the Process Measures at the Interface of Justice and Health, Behavioral Health, and we refer to these as Justice Health Measures. And they map onto some of the CDC ideas for HIV, but we expanded them out a bit. So you can also get this awesome document on the website of CSG, and if you need help doing that, I'm sure Sheila is happy to send along all the links for that. Okay, so what does this document do? Well, first of all, we know that the most important aspect that we're trying to accomplish under this grant award is to actually increase clients screening people for substance use disorder and/or mental health issues or co-occurring disorders, and then helping people walk through the continuum of care. So that involves various different phases of what we need to look at. And one of those phases is screening clients, another is assessing clients, a third one is referring people to appropriate services. The next one is placement in those services, then initiation, engagement, retention, and completion. That's the whole continuum of a system of care. Doesn't matter where you start off, whether the person starts off at the street, whether they start off in an arrest, whether they start off in jail or prison, or in probation or parole or pretrial services. I mean, we can go through all the different places. But the issue is, once someone has some connection to the justice system, and this is reflected in the various types of grants that you all have. Some are diversion projects, some of them are jail-based projects, some are actually enhancements to probation. But regardless of where you start off, the question is, are you screening to find who needs care? Have you assessed that person? What kind of referral mechanism is going on? What do we want to do in terms of trying to get people into the front door of treatment, initiation? What do we want to do to basically engage the person in an active recovery model? How do we retain people? We know dropout rates are especially high. And completion. We also know that about half the people who start treatment don't complete treatment. I'll also add, in this moment that we're at, we also know that there are significant differences in all of these rates by race and gender. We specifically know that we have a more difficult time encouraging people, African Americans, a minority, or people of color, to engage them in some of our treatment services. This has been a common theme, and one, that I think, given the times that we're in, we really need to seriously look at our systems and think about the differential access rates, differential retention rates. I should also mention here, anyone who's really interested in this topic, that the National Association of Drug Court Professionals is doing some really good work right now to deal with the equity issues about access, particularly to problem-solving courts. And I just wanted to mention that because of the time we're in right now and our recognition about how disparity affects access to services in the justice system. So this is kind of what we're trying to do, is basically figure out how, regardless of where people start off, how we can get them into a continuum of care. As part of the interface measures, we developed 4 types of measures. 2 are system level measures and 2 are at the client level. And I've highlighted them here, set 1 and set 4. I'm not really going to go through all of them today, take too long. We have other podcasts and, webinars that we've done in the past. Again, Sheila can direct those to your attention. I've been working with CSG on this issue for a number of years, and CSG has been really committed to trying to get people to think about using these measures. So what I'm going to suggest to you is, one thing we did in that interface document is we presented all the measures. We talk about how you could gather them. But what we haven't done is really use these measures as a way of thinking about your systems and how your systems function and where you have gaps in services. And this is where I'm pulling together the performance management information that Gentry provided and also the concepts behind Cascade. So recently, because of the opioid epidemic, there has been an effort to really begin to think about using the Cascade as a way of looking at our substance abuse treatment system. So some pretty smart people, Arthur Williams, Ed Nunez, and Mark Olson, all at Columbia, decided to basically use the National Household Survey on Drug Use from 2014 to identify, what does the cascade looks like for the opioid disorder. And so they created what's called an opioid cascade model, modification of the HIV Cascade model, I would suggest to you that in the literature, there's a number of different variations, and you should feel free to think about your own system and think about what those variations might look at. But they basically set the goal of trying to basically get at looking at what the estimates are of access to care in different phases, and then what the treatment gaps are. So in this particular graph, they've identified in the dark red area a 90% goal at each stage, what that would look like. And then in the lighter red area, or kind of pinkish area, they identify the gap in services, the number of people who need care who can't get care. So that's called the treatment gap. And then they identify what the current estimates are of how people actually walk through the system in terms of who actually gets access to care. And that's in blue. So it's not a surprise to any of us that what we're really looking at here is that, we can identify people with opioid use disorders, but by the time we get down to trying encouraging people to get access to treatment, which is the third bar, and then actually getting people to begin to use some sort of medication-assisted treatments like Vivitrol, buprenorphine, methadone, whatever your drug of choice or choices might be in your jurisdiction, we're actually showing here that very few people get access, and this, and that there's a huge treatment gap, and it continues. It continues in terms of who stays in care for 6 months, and then who's continuously abstinent or not reusing. So you can see here the cascade can tell a picture. Now imagine this in your jurisdiction. What would it look like? What would you be able to do as a grant coordinator to help people understand, what are the gaps in care and where should we focus our efforts? Now, I know many of your grants vary in terms of what your goals or objectives, but, a movement afoot in the field, and we'll be talking about this later in our series, is really to do some quality improvement models around one of these areas. So it could be engaging people in care. It could be trying to initiate use of medication-assisted treatment, retention, or continuance abstinence. These are goals that you can select for your system, and you can use your grant as a period of time to see what kind of improvements can you make over time to really reduce that treatment gap. And again, kind of acknowledging the times that we're in right now, I would highly recommend that we think about doing these treatment gap analysis or the cascade for different types of populations, whether it be people of color, whether it be women, but it can help us really think about how our system functions and what actually happens when a person goes through this particular scenario. Okay, so this is the big picture. This is relevant to us. So I'm going to talk right now about a recent project that I was involved in. I think there are 20 publications out on this particular project. It was called the Juvenile Justice Trials Project, funded by the National Institute on Drug Abuse. It operated in 33 counties across the United States. And one of the first things we did as part of this project is we basically conceptualized a cascade model that had to do with both looking at how the juvenile justice system at this point and the treatment systems work together to transition youth with substance use disorder and or mental health disorders into treatment services. Okay, so this article that's in Journal of Substance Abuse Treatment the first author is Steve Belinko, and there's a ton of other folks, including myself, that are on this article. But essentially, what we were able to do, and what I like about this graph, is they basically show us that there are certain measures that should come from the justice system. Then there are other transition measures that need to come from either the justice system or the health system, because we know a lot of people don't get services within the justice setting, or there's collaborative relationships to hand off people from justice to health. And then we can also look at some of the issues related to retention, or keeping people engaged and continuing care. So this graph breaks it down by systems, which I think is really helpful, and also makes the case for our interface models, that, we're talking about collecting and integrating data across systems. It also helps us to see where we are in terms of the gaps in services. So using slightly different colors, you can see here that there are a number of, as Steve Belinko calls it, a number of missed opportunities for identifying cases, a number of missed opportunities for treating youth in need. And the need for treating these kids is great, and by doing so, we have missed opportunities in terms of trying to help individuals, particularly fragile youth. And then we have a number of transition-related issues as well as retention issues. So this is the conceptualization of what a cascade for a justice interface sort of model might look like. And then some of the work of the committee or the group that worked on this particular JJ trial study essentially, came up and they defined each of these phases. So I provide this to you, and we're going to be sending you an article that Mike Dennis wrote that kind of gives out all of this information, because next time we're going to actually be talking about how to develop this cascade in your jurisdiction. So I'm not going to go through every one of these definitions, but I want you to know that, they have pretty much operationalized them. And then if you look at the relative rate here, they are also showing you a calculation of how you can define what does screened mean, what does needs identified mean, what does juvenile justice referral mean, what is initiation, engagement, etc. So it's a very useful article. That's why we're going to send it out, so that next time when we talk, you'll have a chance to read it. It's also written really, not like a heavy statistical article, but really written for all of us to kind of digest this approach. All right. So the next thing that Steve Belinko and the colleagues that worked on this study, and this particular effort was led by Mike Dennis, who's at Chestnut Organization, we transitioned the conceptual model that Belinko presented to actually using data from 33 jurisdictions. So again, here you can see that in the community supervision area, they are essentially screening about 68% of the kids that come into the system, and that 48% of the kids that are screened are actually have a substance use disorder. They show you here what's called the actual numbers and then imputed. And the imputed, which is discussed in the article, I'm not really going to get into, is just a statistical method of dealing with counties where they didn't have full data. So we understand that not everybody's going to have a management information system that you can actually get this information from. But at least what we know from the screening and in need, you should be able to get that from your performance management data that you're required to provide to BJA. So we encourage you to think about using that data that way. Okay, so the next piece is transition. So in the juvenile justice agencies that we conducted this study, most of them had a behavioral health partner, and very few actually provided services on site. They usually did some sort of referral. So you can see here, 15% of the kids that were screened were referred. A lot of situations, there were missing data, and so we had to do some statistical methods to impute, but again, I'm not going to talk about that. And then of those who referred, 10% actually initiated care. And as you can see, when we actually look at who gets access to and retains in treatment, the numbers get smaller and smaller. So the Cascade provides a very, very important way of trying to give a picture of how your system's working. So I can tell you that, in this effort and other efforts I've worked on, when you present the whole system picture that looks at the justice system with the substance abuse treatment system and how people march through those, it's eye-opening to see what the gaps are. It's also eye-opening for us to really understand, that we lose people significantly across the system. And, again, this has a lot to do with why we don't make a dent in recidivism rates. Okay, so Mike also provided, there's another way of looking at this, and this is really called the surviving step model. I'm not going to go through that today because I want you to read the article and we can talk about it next time. It's just a way of balancing the denominators, so you're taking account of just looking at the in-need population, not just the prevalence at each data point. And to kind of verify the utility of this approach, the team recently published a paper that compared our 33 counties to national data sources, and this has to come from the National Household Survey and the TEDS data, which is the treatment episode data that's been maintained by SAMHSA, right? So essentially, what this particular, comparison is it compares the National Household Survey data with JJ trial data, and then it compares the TEDS data with JJ trial data. Again, the focus here is to really illustrate how important it is, how valid this approach is, and how much the counties we did our study in were representative of the whole. So I think I have a question here. How do you set up a program to be able to do a cascade? From Sarah. So that's actually what we're going to talk about next time, Sarah, is really how to use your PMT data and how to actually build a cascade at your county level. So if we will continue our dialogue, but we're trying to help you think about how you can also galvanize support. I think what's important about this particular slide, and the reason I wanted to mention it, is how much it can help you really see your own jurisdiction, and it gives you some benchmarks. This particular one, I have one actually that we're working on for the adult system, which I should be able to provide by next time, that will actually allow us to look at what does it look like nationally. So for those of you who don't know, the National Household Survey is actually a survey of households in the U.S. It's done in order for us to get, individual level data on people's need for treatment services, their access to treatment services, and their health disorders. It's a longitudinal survey that's been going on since the 1970s. It was actually President Nixon at that time, as part of his war on drugs, began working on the National Household Survey as a way of looking at drug use in our society. And then TEDS is a data set that SAMHSA maintains that allows us to track discharge data for people who enter treatment. So again, we can get some estimates of how well the systems are functioning. Okay. All right. So I wanted to basically summarize. So I'm presenting this Cascade model to you as a way of thinking about your performance management data that you're required to actually provide to BJA. I want you to think about it as useful data, and I want you to think about how we can use it here to build your own Cascade for your own system. And so I offer the Cascade as a conceptual way of organizing the complex world of treatment care for people involved in the justice system. So we know visualization is really important, and we know that providing data in a way in which you can illustrate points in your system in comparison to other systems is a way of trying to encourage people to really use information. All right. So we have, I think there's one other question. Oh, I think Sheila, you asked, have people heard of the Cascade model before? And whether or not people are using the screening information to really think about how services are provided. So I don't think we can take a poll here, can we, Sheila, to see who's heard of the treatment model?
I would love for people to chat in if you all have heard of the Cascade model, or I know that a lot of you are collecting the information that Faye is describing, screening information, assessment information, connection to services. So I'm curious if you've kind of heard about it and how it relates to this model to identify needs in your system. So I'd love if you all could chat in, and that would be great. One person has heard of it as the funnel. But I'd love for you to chat in and tell me what you've heard or what you've seen.
Let's see. I'm trying to see. I didn't see. I'm trying to. Yeah. I haven't. I don't see that where someone said they've heard of it. Or funnel. But it really is. A funnel is another way of thinking about it. I mean, if you look at this here. I'm going to go back to this one here. It's really a way of kind of looking at, what's the real needs in the system, and then how well are we doing here. Again, what I like about it is because it helps us deal with those harder points of transition. And when you read the Mike Dennis article, what you're going to see in that article is, and the article's not long, it's only 10 pages. So I don't want anyone to think, we're giving you a big homework assignment or anything like that. But essentially, we thought, and I'm happy to give a lot of references. There's more and more being produced on the Cascade model of late. Mainly as a result of the opioid epidemic that we're in the midst of. But, what we wanted to do today is to really begin to help you guys as coordinators think about system building. So Sheila sent around some questions that the team came up with. And we're going to go through these questions and what the results are. So just so you know who's on this call, well, we have about 19 grantee programs here. You come from a lot of different backgrounds. About 8 are working on county approaches to reducing mental health in jails. 6 are focused on mental health training for law enforcement, dispatchers, other first responders. 2 are focused on mental health courts, so you guys will be really interested in some of the work NIDCP is doing on racial equity. 2 are focused on jail programs, and 1 focused on reentry programs. So a number of grantee projects are focused on specific populations, such as young adults and youth and women. Okay, so the first question we asked is to identify the steps that you've taken to assess individuals in your system. Sheila, did you want to add something?
I didn't mean to cut you off, but this session actually ends at 2 today. So we are we're out of time, believe it or not.
Oh, I thought it was 2:30. Oh, excuse me. Okay, well, we will go through this data next time. I apologize to everyone. I thought we were, and we will be sending you some materials. We will be sending you the article by Mike Dennis on the Cascade. The slides will be available. We'll go through the results here, and then we're going to send another assignment for you to think about some of your performance data to make sure that performance, to think about how you could use it to build a cascade. The next session, as Sheila said, we want you online so we can see your faces, but mainly because we're going to do a lot of hard work, rolling up our sleeves to come up with that. And I'm sorry I had all the timing wrong. Don't ask me why. I thought it was 2:30. But, oh, well. Thank you. Sorry.
So much, Faye. And you know what? I think we're going to extend these to an hour and a half. So I'll be reaching out to you all because, as you can see, there's a lot of information to dive into. So I'll be reaching out to you all to see if we could extend the time if that works for your schedules. And I'll be in touch regarding follow-up resources. And Faye, thank you so much for your time today and going through this with us. It sounds like a lot of people are excited to learn about this Cascade model. So I'm excited for our next session. And I know Gentry had to hop off, but thank you to Gentry for joining us today and walking us through the performance measurement tool and those measures and how those relate to data collection and really the foundation of figuring out how your system works together. So thank you all for taking the time today. And thank you all for joining. Have a good one.
Thank you.